I was given the topic of discussing an adult with tetralogy of Fallot. And when I thought about it, traditionally, when you say an adult with tetralogy of Fallot, we would focus mainly on the unoperated adult with tetralogy of Fallot. And that was in the days when we thought that we could cure TOF. But actually, increasingly, we find that the number of patients who have had TOF repair, the adults, way outnumbers the number of actual patients who have uncorrected tetralogy of Fallot during adult life. So the focus of this talk perhaps will be more on the post ICR patients who have had TOF repair. So, like I had hinted, broadly you can classify adults with TOF into unoperated patients, palliated patients, and patients post, intracardiac repair. So if you look at the natural history of TOF, only 25% of them live up to the age of 10, and only 3% of them are still alive at the age of 40. Okay, so there's a significant attrition. So the number of patients living into adulthood with TOF uncorrected, not very high. Historically, if you look at the various kinds of things that we've tried to do for patients with TOF, gives you a bit of a historical timeline. But fairly early on, primary repair in infancy was started. This was in the 1970s. Originally, obviously, we used the BT shunt, but as you can see, early BT shunt mortality, even in a great center like Toronto, was pretty bad. And although this mortality has improved with time, it's still significant even in the present day. Therefore, more and more units now prefer to carry out complete repair of tetralogy of Fallot rather than palliation. I think this is fairly common knowledge anyway. The other disadvantages of the BT shunt are outlined, and I think most of us are aware of these anyway, so I'm not going to spend time on it. So, in the current day, in good centers, TOF repair mortality is even less than 1%, which is outstanding. Okay, and many of our units in India, the pediatric cardiac units, are able to, match those results. So these survivors of intracardiac repair now survive into adulthood. So over 90% of them are surviving, 30 years after surgery. But what we have realized, like I mentioned earlier, is that ICR is not a curative surgery. So TOF, the disease, continues to exist even after you carry out ICR. So post ICR, mainly you have structural issues. You could have ventricular dysfunction. You can have issues with arrhythmia and sudden cardiac death, and of course, psychosocial issues, including pregnancy. So if we look at the structural issues, these are the list of structural issues, perhaps in the order of frequency. Progressive pulmonary regurgitation has turned out to be the biggest problem in post-ICR patients. Of course, you can have branch PA stenoses, residual right ventricular outflow tract obstructions, VSDs, etc. But PR seems to be the biggest problem that we are left to deal with after TOF surgery. The other problem that we uncommonly see but can be a problem is aortic root dilatation. And this can need surgical intervention in later life. So if we look at pulmonary regurgitation, like I said, PR was always thought to be a benign phenomenon, but what we know now is that PR can be a malignant issue. So mild to moderate PR is often well tolerated. So after this realization that PR is a bad thing, surgeons modified their techniques to try and preserve the pulmonary valve as much as possible, perhaps accepting a level of right ventricular outflow tract obstruction, but not really, trying to be too aggressive with your resections of the right ventricular outflow tract. So what does severe PR do? It causes dilatation, dysfunction, arrhythmia, and sudden cardiac death. And PR assessment, in a day-to-day clinic kind of scenario, we tend to use echocardiography, but really it's a very subjective tool. And the gold standard now for PR assessment in post-TOF repair patients is the cardiac MR. So this is just a graph extracted from a paper which showed the correlation between pressure half time, which we can measure on echo, with the regurgitant fraction that can be measured on an MRI. And there is some degree of correlation. So a careful, thorough MR assessment can give us a lot of detail in post TOF ICR patients. And we are mainly looking at right ventricular volumes, the right ventricular ejection fraction, the regurgitant fraction to assess the severity of the pulmonary regurgitation, and of course structural issues like branch pulmonary arteries, etc. And last but not least, also scarring of the myocardium. So late gadolinium enhancement, which can give us some clue as to how prone these patients may be for ventricular arrhythmias. So there's always been the question of how big is too big. And our thresholds are constantly coming down, particularly now that we have transcatheter options. I mean, this is a pre and post valve replacement MRI. But ideally, that's what we want. You know, we want that RV that look that big to become more normal looking. But there is a point of no return. So there is a point after which this doesn't happen. So catching that sweet spot is the difficulty for most of us who are involved in looking after these patients. So this little table that I've extracted out of the AHA guidelines in 2018 gives us a bit of a guide about when to replace the pulmonary valve. So essentially in patients who have more than moderate PR and who are symptomatic and the symptoms cannot be explained by anything else, then the recommendation is to replace the pulmonary valve. In the asymptomatic patients, we have to use other criteria like RV end diastolic volumes. Initially, this RV EDV cutoff used to be 170, 180. Now it's closer to 150. We have an RV ESV cutoff of 80, an ejection fraction less than 45. Any patient with significant PR and sustained arrhythmia problems, and also other, if they have other residual problems, say tricuspid regurgitation due to the RV dilatation, residual lesions in the heart, maybe a residual VSD and moderate plus PR, then you are justified to go ahead and replace the pulmonary valve. So like I mentioned, there are two options, surgical, percutaneous, how to choose. One is the size of the pulmonary valve annulus, because after TOF repair, these annuli can be very large, and finding valves that will sit there and the technical aspects of it can be quite tricky. So there is a cutoff. You cannot replace any pulmonary valve percutaneously. Of course, finance is very important. Surgical pulmonary valve replacement is way cheaper than at this point in time anyway than percutaneous pulmonary valve replacement. What about the results? There was a big meta-analysis that was looked at, and really there is no difference in mortality or reintervention rate between the two techniques. Percutaneous pulmonary valve replacement has fewer complications, shorter hospital stay as you would expect. But one of the unique or slightly strange things about percutaneous pulmonary valve replacement is that it seems to be quite prone to developing infective endocarditis, particularly the initial results with one of the valves called the Melody valve. So this meta-analysis was published in the Annals of Thoracic Surgery for those who are interested. So there are a variety of valves available, and the numbers next to the valves kind of give you a range of the sizes. So like I told you, the bigger RVOTs are difficult for percutaneous pulmonary valve implantation, and all the companies are trying to make the valves bigger and bigger to try and meet this need. There is an Indian, all of these are usually from out of the country. There is one Indian company that has started to make a percutaneous valve recently. But all of these valves still remain expensive for, for the common patient. Okay, just a quick word of the role of the BNP. BNP levels have been looked at in patients with post-TOF ICR, and they do seem to correlate with the degree of pulmonary regurgitation and RV dilatation, as you would expect, I suppose. And they can be used to monitor progress, in the patient. So these are the other problems: residual right ventricular outflow tract obstruction, which can be at any level. And some of it can be dealt with in the cath lab, and some of it needs surgery. Residual VSD is not very common, but can happen. Again, this can be dealt, many a time if it's an awkward position, a large VSD may need repeat surgery. Sometimes we're able to close it with a device. Aortic regurgitation, like I mentioned, aortic root dilatation can be an issue, and sometimes this may be associated with aortic regurgitation. So ventricular dysfunction is the other, next kind of important issue after the structural issues. So various factors may be responsible for this ventricular dysfunction, often we find RV dilatation and dysfunction. But when we have LV dysfunction, this is a particularly poor prognostic feature. So it prognosticates for sudden cardiac death and increased mortality. So we have to look out for LV dysfunction in addition to RV dysfunction. Can be either systolic or diastolic. I don't know what this alarm means. I have a minute. Excellent. So last, we'll just touch upon arrhythmias. You can have atrial arrhythmias in this patient, which are very common, quite common. 30% of adult survivors have atrial arrhythmias. These are usually reentrant arrhythmias around the scar, can be flutter fibrillation as well. Ventricular arrhythmias, less common but more dangerous. Ventricular arrhythmias are associated usually with RV dilatation, prolonged QRS duration, scarring on the cardiac MRI, etc. So for both atrial and ventricular arrhythmias, generally the treatment strategy is look for hemodynamically significant lesions. So if there is significant PR, that needs to be addressed. In addition, try and address the arrhythmia. If there is an arrhythmia substrate, you can ablate it. If there is medical therapy, in addition you want to give it. If there's a high risk of sudden cardiac death, then you may want to also consider an ICD. Okay, so this kind of brings me, I think, to the end of my talk. ICD in TOF, I can just mention briefly. It can be used either for primary prevention or secondary prevention. Obviously, secondary prevention is a no-brainer. Primary prevention, usually the risk factors that we look at, LV dysfunction, history of syncope, recurrent syncope, symptomatic non-sustained VT on Holter, and inducible VT on the EP study. Okay, so these are all the risk factors when you would consider an ICD. Pregnancy, in operated patients, pregnancy is well tolerated. Depends a little bit on the cardiac function as well. So it's an individualized patient-to-patient assessment. But generally, pregnancy not badly tolerated. So how do you look after a TOF patient post-ICR? Annual evaluation, ECG echo. If the patient has pulmonary regurgitation, any evidence of RV dilatation, you'd go for an MRI to use as a baseline or to look at for pulmonary valve replacement. If there's a history of palpitations or syncope, you will consider a Holter, maybe an EP study, which includes a VT stim. If there is exercise limitation or exercise-induced symptoms, consider an exercise tolerance test, or better still, a cardiopulmonary exercise test. So these are all the possible reinterventions. I'm not going to go through them, but we've already touched upon various of these. Cardiac transplantation is the last option if ventricular function is very poor. So as I was supposed to just mention unoperated TOF as well, just some key points. May have neurological sequelae, like cerebral abscess, so you have to look out for that. When you assess them preoperatively, many of them will have aortopulmonary collaterals. You have to address that. The VSD could be restrictive in these patients, and this can lead to ventricular dysfunction itself, RV dysfunction, so you have to look for that. Now, these patients, if they are in poor condition, when they present to you, they may benefit from some initial palliation, transcatheter, like ballooning the valve or RVOT stenting before they are taken up for surgery. So in terms of surgery, generally, the younger age groups, surgery definitely recommended. I'm talking about the adults here. They'll have a slightly more stormy post-operative period, maybe slightly increased mortality compared to the infant ICRs, but still worth doing. I guess it's the really senior TOFs who are very rare anyway, that decision making becomes more complicated, and it has to be done on a case-by-case basis. Another very important point, I'm sure now this is well established. Many of the cyanotic congenital heart disease patients earlier used to have routine venesection. But now this is, definitely contraindicated unless the patient has got symptoms of hyperviscosity. So venesection is not good for these patients. So this is my thanks to all the places that train me, and I thank you for your time as well. Thank you.